Okay, well, welcome everybody. Thank you so much for your interest and for joining us this morning and this evening, depending on whereabouts you are. I just love it. I was telling Charmaine, I'm planning to go to Australia in October for the Sleep Down Under conference that's combined Australia and New Zealand. So Charmaine asked me to present on sleep lab testing and what's useful sleep aids there might be. And that really was a follow-up to my colleague Judith Davidson's talk on insomnia. So I've put together some cases and kind of a spectrum of information for you. And hopefully there'll be some good questions and discussion at the end. So I started off as a sleep researcher person, and my role in the hospital is more managerial these days. So I look after EEG, EMG, and also the epilepsy monitoring unit here. The picture you see on your left is one of our sleep lab bedrooms, and I'm also using it as my background. And that's just a picture of Kingston General Hospital, which sits on Lake Ontario near the beautiful Thousand Islands in Ontario. So it's just a lovely part of the world I've found myself in. So the things I'm going to talk with you about today is just to start off by describing what happens during a sleep study. We call it polysomnography. I'll present some common sleep disorders, but really the focus is going to be on sleep apnea. And then talk about some sleep aids and therapy for sleep. So those might be scattered throughout the talk with you this evening, or today, I should say. Okay, I wanted to just start by a personal anecdote, really. It's what is it that brought me into an interest in clinical sleep medicine? I started off in South Africa at the University of the Witwatersrand in Johannesburg, where I was doing my PhD on sleep and exercise. So the theory of my thesis was on the restorative theory of sleep, looking at exercise, pregnancy, and thermoregulation diet on sleep, whether it's if you have impact, things that use more wear and tear on the body during the day, do you see a rebound and recovery in sleep? So while I was doing that work, this is my Aunt Andre, and she had gone with me. I'd taken her, oh, I'm going to get emotional now. I shouldn't do this. But I'd taken her out to the ballet one evening, and the next morning, I always do this, sorry. My cousin phoned me to say that she had passed away in her sleep. How was she when I left her at home? So just to show you her body habitus and so on, it really just made me think, I'm studying sleep. She passed away in her sleep. What could I have done to make things different? She died far too young. So that took me away from my work in South Africa and research there to come to Canada to learn about clinical sleep disorders, because Canada is actually quite a hotbed for a lot of excellent sleep researchers and sleep medicine. So I came over to Canada and was training and have taken my sleep medicine fellowships. Because sleep is a relatively new field, someone with a PhD rather than MD could get accepted in. It's not the case anymore. So I have been in the field of sleep for 30 years. So the whole process has changed now, but fortunately for me, I could get grandfathered in that way and take the sleep medicine board exams in the States. So I'm sure everybody knows this, but just as a recap, when we look at sleep, the way we record it is from the brain. So hence the pictures of the brain. But we all know that sleep is vital for metabolism, for growth, appetite regulation. Maybe there's time for questions on that, but I can assure you it is. If anyone has worked shifts and has gone or traveled, I guess most of you might have traveled a fair bit, if you're sleep deprived that you get hungry. and you crave the wrong foods. Hormones and cardiovascular regulation are all impacted by sleep. The main thing in the middle, mood, emotion, behavior, empathy, sympathy, how we respond, our own personal self-regulation is impacted by whether we're sleeping well or not and sleeping enough. The other factors is memory, performance, obviously. If you think of top elite athletes these days, they're all trying to regulate and optimize their sleep. Is it Michael Phelps, that amazing swimmer? He actually takes a whole unit to make sure that he has the right sleeping environment whenever he was traveling. And pain management. So that becomes a vicious cycle. If you're not sleeping well, you feel pain more. If you feel pain, you don't sleep well. So how do we break that cycle as well? I'm not going to be talking about that today. So what does it look like when you're hooked up for a sleep study? So it's a bunch of wires, basically. EEG, we record from the brain, different parts of the brain, because the way the brain waves change during sleep is important, and it looks a little different from the front to the back. For example, eye movements. So if you've heard of rapid eye movement sleep, REM sleep, we use those eye recording channels to be able to pick it up. None of this is invasive, by the way. We just have lots of sticky tape, glue, and so on. Sticky paste, not glue anymore. On the chin, for recording muscle tone. If you think about when you're nodding off to sleep, you lose muscle tone, and the tongue, we drool at night. So the muscle we record from is the genioglottal muscle. We also measure breathing efforts, so intercostal muscle. So that's between your ribs. We'll put some electrodes, and on your legs for some sleep disorders and also to record movements. We always include a single channel ECG, and it's amazing how many arrhythmias the sleep technologists pick up at night. Oximetry, it's really just a finger probe that picks up your oxygen levels and heart rate, pulse. Airflow, we use two different ones. And if you see I don't know if you can see my mouse there, Charmaine. If you nod, you can see it. No, okay. So just under the nose, we use two airflow sensors. One is pressure-based, so negative pressure when you breathe in, positive pressure when you breathe out, and temperature-based, cooler air when you breathe in and warmer air when you breathe out. So those are two different measures for airflow. And then we have these stretchy belts around your chest and abdomen for picking up effort, whether you're trying to breathe or not, snoring, obviously, body position. And for some patients, we'd include a measure of carbon dioxide levels, and that's just measured through the skin. My research was on sleep in women, and one of the studies I was doing was looking at upper airway resistance across the menstrual cycle. So here's one of our sleep study participants with this heavy mask on, which was actually stuck on so that we could measure properly. And she had a little catheter down sitting to the back of her throat so that we could measure inspiratory effort. And that was done at the follicular luteal phase of the menstrual cycle. So luckily, mostly we don't use all of these gadgets. And whatever I ask our research people to do, this is me in the other bed with my I was a normal subject for a study looking at patients with chronic obstructive pulmonary disease, where again, it was a catheter down and we had an electrode which measures diaphragm muscle movement in patients with COPD. So these are the extreme where you just have a lot more equipment, but mostly it's as much as you would have seen your normal night that I showed you in the previous slide. So what are we looking at when we're looking at just the brain waves? So really the change is very interesting. When we're awake, if you just think of your brain being very active, the frequency of the waves is very fast and it's a low amplitude, so it's busy. I always try and describe it. If you think if you're at a concert and everyone's clapping wild applause. It's that kind of wild firing. It goes really fast. When you go into stage 1 of non-REM sleep, I mentioned about REM. It's also when you have most of your vivid dreaming, but stage 1 of non-REM is like that kind of church sleep, when you're starting to nod off, just that initial shutting out of the environment. You have very distinctive waves, but a little changing, a little slowing in the brain waves. Stage 2 is really, it takes up about 50% of our night is spent in stage 2 non-REM sleep. It has very characteristic sleep spindles and these K complexes. Stage 3 is called, and it's called slow wave sleep as well. And you can see why, because of these really big waves. So if I go back to the analogy of an audience with everyone clapping super fast and all together, it's very random. But as soon as it slows down and everyone claps together, it becomes synchronized, it becomes louder, and it becomes much bigger. So that's really what's happening when you're in your deepest phase of sleep. You can see the change from relaxed wakefulness, fast activity, to deep sleep, big slow waves. So if you think about it, that's the time your deep sleep is when, if you've ever woken up like with a sleep hangover, or it takes you a while just to shake the cobwebs out of your head, you probably have been in this deep slow wave sleep. If you look at the very bottom tracing, these are all 30 seconds, by the way. The bottom tracing, the EEG, our brain activity, goes back to being fast, similar to what it is in wake. So when we're in this rapid eye movement phase of sleep, because we have very phasic rapid eye movements at the same time, your brain is similar to wake. Your brain is active. It's much easier to wake up from that phase of sleep because your brain is active already. What happens with REM is when we have most of our vivid dreaming during that phase of sleep. You can dream in any phase of sleep, but the more vivid dreams happen during rapid eye movement sleep. So that's why people also refer to it as dreaming sleep. During this phase of sleep, our skeletal muscles that hold us up are paralyzed. Why would that be? Why do you think that might be, that when you're having a dreaming phase of sleep, your muscle tone is gone? Just giving you a moment to think about it. But it makes sense, really, because you don't want to enact your dream. If you're having a scary, frightening dream, you don't want to be running around and, or hitting somebody. So that's one of the sleep disorders, is where people enact their dreams. And that's called REM sleep behavior disorder, where people are having these vivid dreams and they can be enacting them during the night. That happens, usually it's in older individuals, 70 plus, but we do see it in younger individuals depending on what medication they might be on. But REM sleep is really a very interesting phase of sleep indeed. My work on the restorative theory of sleep was looking at deep sleep, because deep sleep is associated with growth hormone release. So we think we know that that's a period of more growth and restoration. So different functions. I'll just pause there, because people often want to know what is the function of sleep, and there's not one single function of sleep. There's a myriad, in my view, of reasons why we need to sleep. And here's another one of them, the wonder of the sleeping brain. This is a time when our brain has a chance to have a rest period for house cleaning. I'm really quoting one of the lead author here, Maike Nedergaard, and this group have done absolutely amazing work. You know that the brain is protected by what's called the blood-brain barrier. So big particles can't get in, but they also can't get out. So how does the brain clean itself of things that build up during the course of the day? And your sleep time is one of those times where the ventricles open, and it's called actually the glymphatic system. And you can see during wake time, these ventricles are small, very little flow. Whereas on the other side, when you're asleep, it's opened up. So that whole cerebrospinal fluid can come through. It can pick up all of these extra proteins and so on and clear them out. So this really is what we've recognized now. It helps to clear out beta amyloid plaques, which are implicated in Alzheimer's and dementia. So that whole process of allowing your brain time to sleep is really critical. This is really new work from the last few years. So I think it's amazing. I just like to include it whenever I can in these presentations. Just to go through what is our normal sleep architecture, and I'm using a young adult over here. All right, so if we look at sleep cycle with a young adult, we have phases of non-REM and REM sleep. So REM sleep, because the EEG is close to wake, you can see here those colored bars are close back to the wake period. When you first go to sleep, we go through non-REM sleep, light sleep, stage 2 sleep, and then your deep sleep of the night. And around 90 minutes after falling asleep, 70 to 90 minutes, you have your first period of REM sleep of the night. So our sleep is in cycles, 4 or 5 cycles, depending on how long they are and how long you sleep, of non-REM ending with REM sleep. That's always how it goes, unless you have a particular sleep disorder, for example, narcolepsy, where you go into REM before non-REM. I want to also point out 2 other things. When you first go to sleep, if you look at that, you see most of your deep sleep happens in those first 2 cycles. Your REM sleep periods get longer towards the early hours of the morning. Again, this makes perfect sense. When you first want to go to sleep, deep sleep, and Judith spoke to you about process S, that builds up, your sleep need builds up when you're awake, and it dissipates exponentially through the course of the night. So there's your deep sleep happening in the first 2 cycles. REM sleep starts off short and it gets longer towards the early hours of the morning. Again, that makes sense if you think about you getting ready to get up in the early hours of the morning. So your brain is already closer to an awake state at the end of the morning. I spoke a little bit about growth hormone. You have most of your growth hormone secretion happening in the first part of the night. And the other hormone that's regulated or that's associated with sleep is cortisol, which you might know as a stress hormone. Cortisol is low when you first go to sleep, and it starts to increase towards the morning. Again, that makes sense. Waking is stressful, but hey, we need to live in a stressful environment and cope with it. And there again, your body is beautifully regulated to adapt to that. So what happens as we get older? So here we are at the older adult. So there's a nice young, healthy sleep cycles. And this is called a hypnogram, by the way. And then here we have an older individual. So a number of things happen, but I'm just going to point out 2 main aspects. 1, less deep sleep. Too bad for all of us. And the other one is more awakenings. Another too bad for all of us. And what happens is when you wake up is that it might take you longer to fall asleep. The good piece, REM proportion stays pretty much the same. So if we're thinking of maybe REM being involved in memory consolidation and so on, the REM proportion stays, and it's pretty much consistent throughout life. The only ones who have a lot more REM are infants, because that's brain development and maturation. So this is our sleep as we get older. If I mentioned about growth hormone, you can see, because you've also got slow wave sleep, it's really linked to those delta waves. The amount of growth hormone is reduced as we get older too. That's enough of the background of sleep. I just wanted to touch on some of the sleep disorders. And the classification that we use is through the American Board of Sleep Medicine, the International Classification of Sleep Disorders. And we're on the 3rd edition with a recent revision. But basically, I think of it as 6 different categories. The last one, the 7th, is really just environment, and it's nothing really. Insomnia, I know Judith has spoken with you about. Sleep-related breathing disorders, I'm going to focus on obstructive sleep apnea mostly. I've included catathrenia. Have any of you ever heard of that word, catathrenia? I just love saying it. It just sounds, and it actually means sleep groaning. So some people have catathrenia where they groan during their sleep. It's different than snoring. Disorders of hypersomnia. I mentioned about narcolepsy. So narcolepsy is where the boundaries between wake, non-REM, and REM are blurred, and people go straight from wake into rapid eye movement sleep. So that's an example of hypersomnia. There are some others. Circadian rhythm, sleep-wake disorders. So I deal with shift workers all the time. I feel terrible for the sleep technologists having to stay awake and watch other people, hospitals, everywhere. There's so many people working shifts these days, whenever we fly, so on. Delayed sleep phase syndrome. That's more common with adolescents, a normal part of growing up, that they have a delayed sleep phase. Anyone who's had teenagers or has them knows they want to go to bed later and wake up later. So that's just a natural part of their circadian rhythm evolution. Circadian, I'm sure you know, is a circadian around 24 hours. Parasomnias, I've already mentioned about REM sleep behavior disorder, sleepwalking. Sleep talking is kind of a normal variant. And then movement disorders in your sleep. So one is teeth grinding. So dentists do well with trying to help people fit appliances, oral appliances, and periodic limb movements in your sleep. And I'll show you an example of that. So if we just focus on sleep-related breathing disorders, this really is a spectrum. So when you first go to sleep, you get a normal increase in upper airways. That makes sense. You've changed body position, your muscles relax, so there's a little bit of narrowing in the airway. Snoring, at least if you're snoring, you know you're breathing, is one of the aspects. It's a narrower airway. Snoring is a sign that things may be getting worse, and it's very disruptive for the bed partners. Upper airway resistance syndrome is, again, just a narrowing of the airway, and we call it a syndrome when that narrowing does result in a consequence of waking up or a decrease in your oxygen levels. But the two main ones that people know about is obstructive sleep apnea, where the airway is occluded, and obesity hypoventilation syndrome is another extreme from there. And the other type of sleep apnea is central, and that's central really is when the brain doesn't tell the body to breathe, basically, and there are different reasons for that. One, for example, is with opioids. So people with overdose of opioids, central apnea is what happens, and people just stop breathing. So apnea literally means without breath. And what we see in the lab is repeated episodes where the upper airway is obstructed. It might just be partially obstructed or totally occluded. And it's usually associated with a decrease in oxygen levels and or a brief awakening. So when we talk about arousal in sleep, it's a different kind of arousal. It's awakening. And we count those that are lasting for 3 seconds or more. And the syndrome of obstructive sleep apnea comes along with complaints of unrefreshing sleep, morning headache, dry mouth, I'll come back to that too, nocturia, if you have to get up to the washroom more than once a night, excessive daytime sleepiness. And that's also because of the consequence of waking up repeatedly. I'm not going to go into detail here, but women are a little different than men in their presentation, in that sometimes women may be presenting with insomnia, depression, whereas with men, it's more commonly excessive daytime sleepiness. But it's not always the case that way, but it just means the presentation might be a little bit different between men and women. It is often different between men and women. So what's happening with this is here where we see with the normal airway, open, patent, you're lying down, the tongue's not back, the soft palate's open, you can get air going right through into the lungs. if the tongue falls back or the uvula, the soft palate, it can go back a little bit or a lot and literally block the airway. So it's like you're suffocating basically at nighttime. So if you are suffocating, what has to happen to make you resume breathing it's most times is that you have to wake up to then resume breathing. So people's sleep becomes very disrupted. When we're looking in the sleep lab and we're getting an index of how the severity of sleep apnea, we count any events that last 10 seconds or more. 10 seconds is really 2 breath cycles. So if you just hold your breath for 2 cycles, 10 seconds, if that happens at night repeatedly, and it's your airway is totally gone, we count those. A hypopnea is if there's still a little bit of airflow, but it has to result in a physiological consequence. Either you have an arousal or your oxygen levels go down, and this varies between labs, either a 3% or a 4% decrease in oxygen levels. So those are counted. We also include a respiratory disturbance index. These are events per hour, if you've ever had a report. Respiratory disturbance index is different than the AHI in that it could include snore arousals or else this respiratory effort-related arousal where you have airway closing and narrowing and wakes you up. We're also recognizing that there's a difference because sometimes people just have a lot of short apneas, so your index is going to be high. Anything over 30 is considered severe. But sometimes people have long events, like 2 minutes, if it's just airway narrowing and then you wake up. So you have to really look at the proper profile of what's happening during the course of someone's night. And people are looking more now at what's called an oxygen desaturation index, is how often does your oxygen level go below 3 or 4%, and how much time is spent below 90% during the night. So, still really trying to perfect what measures to use. So if those are apneas, I just want to speak a little bit about the obesity hyperventilation syndrome. And this is really because just last month, a few weeks ago, we had someone who'd been in ICU, really only because he had what's called Pickwickian syndrome. So I love these early descriptions from Charles Dickens' Pickwick Papers, the Fat Boy Joe. And a colleague actually gave me this as a card, the lid of a card holder. So originally, obesity hyperventilation syndrome, you'll also see it referred to as Pickwickian syndrome because of the Pickwick Papers. But I just love this description, the first description, 1956. If you're playing, I don't know how many of you play poker, but basically if you have a full house, and you miss it because you've fallen asleep, that's not a good sign. So in 1956, the treatment for obesity hyperventilation would have been a tracheostomy, basically, just to make a hole in the trachea so that the air could go through. Things have changed since then. The biggest change really came with an Australian. Colin Sullivan was a physician in Australia, and he came and did a postdoctoral, he did a fellowship in Toronto with Elliot Phillipson. They were working on animal studies, looking at ways of opening the airway, and amongst other things. But basically, once he got back to Australia, he started working on designing the first CPAP in the 1980s. And they were using dogs, gluing these masks on. So it really was cobbling something together. And I love hearing how these things evolve. Huge machine. It's really just like a reverse vacuum cleaner. He found his first patient. This is a construction worker who actually fell asleep on the ledge of, a high building. So I think everyone made sure that he got a consult. So rather than having a tracheostomy, he was a younger gentleman, I think he was around 32, he decided he would be the first person to try the nasal CPAP. And there's your first paper in 1981. If I could, I would add a little song here because just out of interest, if any of you are music aficionados, but Queen Under Pressure, 1981, came out at the same time. And I just thought that's so appropriate. CPAP Pressure and Queen's tune. Anyway, little aside. So what does it look like? It's really evolved a lot over this time. Actually, Under Pressure, I think, was only a hit in the UK. It didn't reach #1 anywhere else in the world. Anyway, CPAP therapy, continuous positive airway pressure. So literally reverse vacuum cleaner, air blows through, positive air pressure. You have to wear an interface, nose, mouth, usually both, just depends on each person. The most important thing is really fitting the right mask. We titrate the pressure for each specific individual. And at the very bottom, it just shows you the heated humidification chamber. So originally it was just what we called a cold passover, basically just cold air blowing in through the nose under pressure. And that over time, now we get heated humidification and so on. So it makes it much more comfortable for people to adjust to using the therapy. So I'm going to show you this 24-year-old man who they didn't want to discharge him from the ICU because he was just so profoundly severe. So he presented to the emergency room. He was unable to breathe, morbidly obese. He was admitted to ICU, low oxygen levels, low heart rate, and witnessed apnea. Compounding that is that he also has upper airway features where he can't breathe through his nose properly. He's had a broken noses. So we couldn't fit him in the lab right away. He went home on a CPAP trial, so they got him sorted out. And he came back. I think we got him in within 3 or 4 days. I think mostly we didn't have, the lab wasn't open. Anyway, I'm going to show you what we see from the graphs for his overnight study. So you remember the hypnogram I showed you in the last one, which is really just again at the top. So REM in our patterns here is still, you can still see it nice and easily along the top. Awakenings at the very top. So the green bars are REM. The respiratory events show a range, a lot of them through the night, but I want to draw your attention to what's called the SpO2, the oxygen levels. Normally, he should be sitting around 94, 95%, which he does when he's awake. As soon as he falls asleep, his oxygen levels plummet down to the 70s. He wakes up. When he wakes up again, you can see his oxygen levels increase. So he has this little sawtooth pattern, if you like, of desaturations and events. We do what's called a split night, where when people are really bad, we know he needs therapy, we know he's used it at home. So we start therapy partway through the night, and the very bottom bar shows where there's no therapy. And then when we start CPAP at 6 centimeters of water pressure, initially, it's not enough. You can still see his oxygen levels going down. And then you suddenly hit a sweet spot where his inter-REM is just woken up and then he's back to sleep. So ideally, if you're looking at oxygen levels, you just want oxygen levels to stay steady continuously around 94%. So it's always very affirming for the technologists to know, within one night, you can really help to sort people out. It's truly a remarkable, everything in one night. It's just remarkable the difference that this makes for people. If you can imagine, if you just held your breath for 20 seconds, while I'm talking, try and do that and hold, and see if you can, how you feel breaking through that 10-second period. But if you're doing that right throughout the night, it really does have a profound impact on people. So this
I know, Helen, that he doesn't have any stage 4 sleep, even with the
Thank you. Yes, excellent. So yes, he had very little, and then he has what's called rebound. Thank you for pointing that out, because as he's then allowed to facilitate sleep, and he's having a rebound in REM sleep, his REM sleep periods are longer. You should normally only have, REM sleep lasting 45 minutes, but people can go 2 hours. His isn't as extraordinary as I've seen. But I just pulled his one because it was just last month. So there you go. But I'm going to show you a 2-minute window of what we see. This is the graph summary, and this is what we see overnight. So we would score the sleep stages in 30-second windows. But when we do respiratory events, we can compress it. So this is a 120-second window. And I've stated its wake. But if you notice, as soon as right in the middle, he's starting to fall asleep, even little micro sleeps. The two graphs to draw your attention to is the pink one, nasal pressure, and then the other one called airflow, where you notice that it goes flatter. And it's just for like 10 seconds. And I've left these marked in where he has desaturations in his oxygen levels. The little yellow bursts are little bits of snoring. So he's not actually a big snorer. He doesn't have time to snore because his airway just collapses right away. So again, when I said snoring, it means you're breathing. Sometimes, you have to worry if you don't hear the snoring, because then the airway might have totally occluded. But these are, can you imagine just going through that? And you'll notice each time when he does resume breathing, there's an increase in muscle tone, a little arousal as well. His heart rate is high. His oxygen levels have gone down. He's literally fighting for breath when he goes to sleep. This is when he's now in consolidated sleep, N2, and now he's just having one apnea after the next. Oxygen desaturation, one after the next. It's truly remarkable how people can cope with that kind of sleep disruption. When he's on CPAP, this is his rapid eye movement sleep. The blue lines just underneath the top 4 black ones are the EEG. But here you can see very rapid eye movements. People have a rebound in phasic REM. Sometimes people say, I had such amazing dreams when that happens. And you notice the CPAP flow. His airway is good, and his oxygen levels are at 98%, 96 to 98%, just perfect. So all in one night have totally sorted him out. I'm going to move on to that's with men, but do women have the same thing? Yes, we certainly do. And unfortunately, postmenopausal, women are protected from obstructive sleep apnea when we have our menstrual cycles. But postmenopausally, we like to catch up with men, it seems, on this front of having obstructive sleep apnea. So this is a 58-year-old woman, teacher, who had complaints of snoring, witnessed apneas, daytime fatigue. So these daytime fatigue is a very common way that women may describe how they are feeling. And people can differentiate between fatigue, sleepiness, tiredness. There's really a distinction between those. So this is her stage 2 sleep. I want to point out 2 things. If you can see the yellow bursts, that's her snoring, and her airway is collapsing a little bit when that happens. But she also has periodic leg movements during her sleep. Those are the little green bursts. And sometimes people have, you don't necessarily only have one and done sleep disorder. You can have a combination of them, unfortunately. And for her, she has the 2 sets of things. So she's got snoring as one in this part, and she also has repeated little leg movements. It might just be a little bit of dorsiflexion, just like your big toe moving. Sometimes it's the whole ankle moving. Sometimes people are like pedaling a bicycle in their sleep. But just that little periodic movement can also be disruptive for sleep. It is associated with a syndrome called restless legs syndrome, where people feel like a creepy crawly sensation, Charlie horses it's described as, where that happens when you're sitting quietly. It happens in the evening more. And then not everyone who has restless legs has periodic leg movements in sleep as well. So the 2 distinct movement disorders, but they can overlap. So that's with her. And then when she hits REM, which is in the next example, Here's her rapid eye movement sleep. There's phasic eye movements at the end, and right at that time is when her airway closes as well. What you see when people have an obstructive airway is that you can watch kids or watch people sleeping, is the breathing, instead of staying in sync with your chest and abdomen going together, synchronized, you see they go against each other, collapsed airway, and they literally, your belly goes in and out as people are trying, as we call it, paradoxical effort, paradoxical breathing, as people are trying to get their airway open. And then right at the end of that 2-minute window, she wakes up again. So this is her hypnogram. She has REM periods. You can see her sleep cycles look pretty okay. Also, Charmaine, you'll notice her N3 is not in the first cycle. It's switched to the second one, which is unusual. Her oxygen levels are, that's the third graph, are mostly fine, except when she's in REM sleep on her back. So that's another form of therapy. You don't necessarily need to have CPAP therapy. For some people, positional therapy might be effective. Make sure you never sleep on your back. You have to really be quite aggressive about it, or else elevate the head of the bed. And then she's also got some leg movements happening here. So I wanted to just touch on something else that people have been talking about. I don't know if it was a fad that reached to Australia as well, but there was suddenly this TikTok thing of mouth taping. So people were mouth taping to make sure that they slept well. You know, it's just craziness. So they literally just used a piece of tape to close mouth up, and this all came, it's actually an excellent book, Nesbitt, called Breathe. The issue really is not force yourself to breathe through your nose. Why are you not breathing through your nose? You know, not just make sure you breathe through your nose. Is your upper airway blocked? Is your nasal passage blocked? Why can't you breathe through your nose? So that's one of the things. If you wake up with a dry mouth, you don't have sleep apnea, you know, that's one of the things. You can maybe try nasal dilators and so on. But just to close off your mouth like that might be blocking off the only airway that you're getting air in when you need to. Anyway, it's not recommended. And here's one of the reasons why is it bad if you are breathing only through your mouth. So it is, the premise is right. You should be breathing through your nose. This is a research study we did a few years back, again with the Pneumotach, but you'll notice this Pneumotach has a piece over the nose and a piece over the mouth. So studies looking at oral nasal breathing sometimes stuff things into people's noses so they can't breathe through their nose, but you also have receptors in the nose. So, you know, you're not getting a true signal. We all know what it's like when you have a cold and you can't breathe through your nose. You wake up with a dry mouth, you're not sleeping well. So effectively, this is what we're mimicking. With the Pneumotach, you can close off the port in the nasal piece or the mouthpiece over the oral piece. So we can partition, and there's a little partition right across on the upper lip, so that you can say, I'm only going to breathe, we're going to close it off, so you can only breathe through your nose, or so you close the mouth and only nasal breathing, or you close the nose piece and only oral breathing without sticking anything in. Of course, this contraption is uncomfortable, but at least you're not sticking anything in the nose. What happens when you do that? And I think we all know, if you have a cold, you just know that you keep waking up at night because you can't breathe. And that's really what happens. This is normal, healthy individuals. We did that too. When we force people to breathe through their mouth only, this is the apnea-hypopnea index I spoke about. This causes severe apnea. If you're breathing through your nose, you breathe beautifully. So we're meant to breathe through our nose. Why is it? If you look for the reason why you can't if you are not. So just to summarize there, we've spoken about sleep aids. These are your therapy for sleep apnea. CPAP, you get auto-adjusting APAP. bi-level BiPAP, weight loss, positional therapy I mentioned, oral appliances, so you can move the jaw or dentist not only for tooth grinding, but a better splint that advances the mandible. And surgeries for kids, TNA, adenotonsillectomies, great. If you see kids only breathing through their mouth when they are awake or asleep, that's a big sign. Make sure they get that sorted out. TNAs, people don't do them often, but it kind of went out of favor. But if kids are oral breathing, that's really something to try and make sure. With kids, they're hyperactive, they're breathing through their mouth, you get that seen too. Nasal, if it's deviated septum, etc., and uvular palatopharyngoplasty, UPPP, very painful procedure where they take away the uvula. And it just depends. And that just shows it's a range of reasons and parts of the airway that might collapse during sleep. I'm just coming to the end now, and I wanted to let you know again that dreaming permits us to be quietly and safely insane every night of our lives. I just love this. We all dream. You have to wake up from your dream in order to remember it. So some people wanting to remember their dreams keep a little sleep diary, for example. I alluded to this, I'm not going to speak much more, but as we get older, I spoke about adolescents wanting to go to bed later, but as we get older, we become more lark-like. We want to go to bed earlier. So seniors, we have an advanced sleep phase. I have an advanced sleep phase. Larks, early to bed, early to rise. We also have reduced melatonin, difficulty maintaining sleep in the early morning. And sometimes environmental cues are weak. And I really just want to really emphasize light is such a beautiful thing to make sure that we get it at the right time of the day. So I told Charmaine I was showing pictures from Canada. This is north of where Charmaine lives at Sharbot Lake. So this is from a friend's cottage. And if you're looking at it, I wonder how many of you would know which one is sunrise and which one is sunset. So the one on the left is sunrise, blue colors. A fisherman friend of me told me the water's calm. Apparently the water ripples more in the evenings. And in the evening, you have your red sunset. So we don't always see it like that, but that's really within our spectrum is how it should be. Blue light in the morning, red light at night. What are we doing to ourselves? Do not be on your devices late at night. Our bodies are made more for red light at night. Blue light impacts our production of melatonin. It's also impacting how we all behave. This really happened through COVID, but I love this term of revenge bedtime procrastination, when people value their freedom, especially people who have hectically busy days and you just want a little bit of time for yourself. And that's me time is on the phone late at night. So the need for control surpasses the need for sleep. And I see that actually, it really makes me mad for people who are coming to the sleep lab. You only have a short window when they're meant to sleep. And I've asked the technologist, please make sure people put their device away at least by midnight. Why are you here? Is they going to get you up at 5 or at 6 in the morning usually to get up? But people have delayed themselves using devices in the bedroom at night. Why is this important? So we see the light-dark cycle. Light falling on the suprachiasmatic nucleus impacts what's called the pineal gland. Blue light suppresses the production of melatonin. So melatonin is also known as the hormone of darkness or the Dracula hormone. It comes out at night. It's suppressed by sunlight. And it feeds into all of these other loops that we've spoken about already. So I'll focus on melatonin, and just like mouth taping, here's another thing that's getting me mad. Melatonin over the counter. This is huge business. It tells me people are having problems with sleep because this is big bucks. But really, all I want to point out here is people should read labels. Just because it's over the counter, natural products, it doesn't mean that it doesn't have side effects and it can't cause harm. It's really a big business. There are some good things to it. It's multifactorial. Melatonin is a chronobiotic. It helps synchronize your rhythm. So jet lag, great to use it. Use it at the right time, maybe for a short time. Any sleep aid for insomnia is really, you want to use it for a short period of time. The best way is for us to control our own rhythms. So read the labels and read up before you buy. When I was taking this photograph at Costco, a woman came and said, "This stuff is amazing. It's so good. I sometimes take 2." And I just went, "Oh," because it's also not regulated. You don't know if you're getting the concentration they tell you it is. And it's supraphysiological doses. These are higher doses than you actually, the one on the label, one of them was a lower dose, which is better. Plus, one of them had, anyway, I won't go into the rest there. So I want to wrap up now after I've had a little rant there. Just to, what do we need to do? I mentioned about revenge bedtime procrastination. What do we have to do to improve our sleep? Avoid the couch, avoid binge watching, avoid doom scrolling. This was all prevalent during COVID. Caffeine and alcohol. Here's another thing. Alcohol will get you to sleep, but once alcohol's worn off, you'll wake up. So it disrupts sleep later on in the night. Caffeine. Do you know that coffee is the second most traded commodity in the world? What does that tell you about our society? So there we go. We're buying coffee, and I love coffee. I really like, when I come to Australia, I'm going to try out all the little coffee shops, but I don't have coffee, definitely not after midday. And what was I going to say? So there's coffee, and then people are taking sleep aids at the other end of it. So make sure if you're having caffeine, time it in the morning. Remember the half-life of caffeine to make sure by the time you go to bed, you don't have any caffeine in your system. Caffeine is an adenosine antagonist. Adenosine is a marker of that process S that builds up through the course of the day and dissipates at night. So you're blocking that sleep drive that adenosine is giving us. What should you do? Make your bed. Make sure you have a cozy, comfortable environment. I like to take a walk before bedtime. You get up, you're moving, your body temperature goes up, you're getting some activity, even just going, brushing your teeth, getting ready for bed. Make sure if you've been on the couch or seated that you spend some time walking. And then when you lie down, body temperature goes down. That helps to facilitate your sleep. Leave digital devices out of the bedroom. I bet you knew I was going to say that. If you're using it as an alarm clock, put it in another room so you get up and switch it off. It does not have to be right beside your bed. Thank you for your attention.